Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
I'm Sarah de Vlieger and I'm here in London with David Rees, part of our education committee at the European Hematology Association. David, could you please introduce yourself?
Hi, I'm David Rees. I'm a paediatric hematologist at King's College Hospital and I look after children with sickle cell disease and have been involved in screening and managing them for quite a long time. And I was involved in setting up the screening program in the UK.
And we are here to talk about screening today, David. So could you maybe give us a feeling of what you would consider standard of care for or gold standard for screening in sickle cell disease?
Well, there's two main points where screening's done. One is in most countries is antenatally, when someone's pregnant and you want to identify whether the baby, the fetus the woman is carrying could be at risk of having sickle cell disease. And that's called antenatal screening. And then the other screening is testing babies when they've been born, neonatal screening, and that again is an important factor to try and identify children with sickle cell disease so that they can be treated and managed before they present with complications or even die in the days before screening.
Could you take us through the process, perhaps first, of antenatal screening?
Well, antenatal screening is complicated and it varies a lot depending on where you are and what the prevalence is, how common the situation is. In the UK and lots of in parts of the UK, in cities like London and Birmingham, Manchester, where there's a high prevalence, and same in European countries, then the idea is that every woman, when she books for pregnancy, is also tested to see whether she could carry sickle cell or thalassemia, which involves having a full blood count and also hemoglobin analysis to look for the presence of sickle hemoglobin. And then if she is a sickle carrier or a thalassemia carrier, then the next step would be to invite her partner, the father of the pregnancy, to come and be tested also. And if both of those people are carriers that put the fetus at risk of developing a significant hemoglobinopathy, then the couple are counselled regarding that risk. And what the counselling's for depends a bit what country you're in. The idea is to give mothers choice so that they know, or couples choice so that they know they're at risk of having an affected baby, and the choice is really involves, part of that choice is whether they want to continue the pregnancy and have a termination. Obviously that varies quite a lot culturally, and in the UK that is the primary purpose of the antenatal screening program. In some countries it's more about choice and giving information so that people can prepare for the possibility of having a child with a medical condition.
I can imagine that's quite a difficult conversation to have.
It depends. One key thing is as it stands, antenatal screening carries if both couples are at risk, then the next step is to have prenatal diagnostic testing, where you have the standard is to have an invasive test involving an amniocentesis or chorionic villus sampling, where you put a needle into the womb, which is firstly uncomfortable and secondly does increase the risk of miscarriage by a small amount. Probably it's only a very small amount, but it's probably still there. And so the test isn't something people can do casually, in the sense that you have to be sure that you want to know this information really. Mm-hmm. And you have to be sure that the information is going to be useful, in the sense that you're putting the fetus at risk, and it's not just like a harmless blood test where you get the information and you can once you've got the information, you can decide what you want to do with it. You have to really think why you're having the test done. People are developing, there are available and they're in development ways of doing the test by using maternal blood, so in a non-invasive way, because there are small amounts of DNA and cells from the fetus in a mother's blood when they're pregnant, and you can test that, although it's technically still quite difficult to try and identify whether the fetus is affected by sickle or not. That can be done, although it's still not 100% sensitive and specific. It's still not of the standard required for a prenatal diagnosis, but it is being developed, and that is likely to become an important option in the fairly near future.
Okay, and chorionic villus sampling, can that be done at any point during pregnancy?
No, I mean, I think it has to be done can't be done before about 11 weeks, 10 or 11 weeks. People went through a phase of doing, people used to do it earlier, and it caused fetal abnormalities, it caused loss of fetal limbs and things like that. So 11, 12 weeks is the earliest it can be done, and it can be done up to about 14 or 15 weeks, and after that amniocentesis tends to be done, where you just take the fluid out from around the baby. The earlier it can be done, the better, in the sense that if you're taking a choice about terminating a pregnancy, that's a much easier decision, really, if you're early on in the pregnancy. Or certainly termination is much easier if you're 8 weeks pregnant compared to 16 weeks pregnant. So it makes it a slightly different choice and a more realistic choice, which is where the non-invasive testing also has an advantage. That can be done earlier.
What's the utility of doing invasive tests in an area or a country where termination might not be an option?
Well, I think it's a more difficult question. Certainly, medical termination is an option in many countries, and sometimes individual mothers may choose to leave the country that they're in and move to a country to have the termination where the fetus is affected. It is useful information, and some people in this country want to know. They know they won't have a termination, but they feel they want to know, that they want to prepare themselves mentally for having a baby who could have medical problems. Because sickle cell disease doesn't affect the fetus in the womb, and it doesn't really have cause any clinical problems till a few months of life at the earliest. There's no strong medical reason for finding out. It doesn't alter how the pregnancy is managed or how the birth is managed. But for some people, it is, it's important information, and they just want to mentally prepare for having a baby with that. I think the other important point about it is that I think you can't make any assumptions about what people will choose, and the idea that if you're Catholic or Muslim, you wouldn't necessarily consider termination isn't individually true, and it's important that everyone is offered the choices in the same way, and you don't have any preconceptions, certainly. So in most of the world, then termination isn't legal, but and in most of the world where sickle cell occurs, then it's either not available or not legal. Although medical termination, which we're sort of talking about, is has different rules applying to it.
Okay, so say a mother hasn't chosen to undergo screening during pregnancy, what would be a reason to screen a child after it, or a baby once it's born, a neonate?
Well, in the UK, and I think most people think that it should happen in nearly every country where sickle cell occurs, then every baby is tested, so that every baby at birth, after 7 or 8 days of life, a heel prick is tested, and that spot of blood is used for looking for lots of conditions, including cystic fibrosis and phenylketonuria, and sickle cell has been added to that. So every baby is born in the UK who is tested for that, and that's true in some states in the United States and some European countries. I think France probably now. The alternative is and what used to happen is that I try and identify babies at high risk of having sickle by it may be their mothers have been tested, all based on their apparent ethnicity, or sickle is more common in some parts of the world. It's relatively uncommon in Northern Europeans, and it's relatively common in families of African origin. So that in some countries people identify high-risk pregnancies based on the ethnicity. In the UK, it was discussed and it used to happen, but it's become impractical in that people have, it's difficult to know. It's difficult to know what the right question is, and you can't rely on the colour of someone's skin or if they've got a funny sounding name. You have to have some objective way, and whether you're saying, all 4 grandparents have to be born in a Northern European country, and that's not true of many people now in London. The vast majority of people have quite complex and mixed race origins. And it's also to do that properly, to use someone's ethnicity to determine the fetal risk, it takes quite a long time, and in a way it's quicker and cheaper just to do the test. So the idea was that you can avoid doing too many blood tests, which were perceived as being expensive, by selecting the babies who are at higher risk. So in the UK it's universal neonatal screening for sickle, and I think that is the idea is that that really maybe should be used across Europe, and lots of people think that that should apply in every European country now that the numbers of people with sickle cell is increasing really across Europe. In previous low prevalence areas, it's now quite common. And I should say, related to that, EHA are now developing guidelines on this specifically. There's a working party to develop guidelines on neonatal, I think just on neonatal screening, so exactly who should be tested and how they should be tested, and and whether what countries should test really, how many affected births do you have to have before this sort of thing is included.
Okay. Do you often find that there are challenges in approaching screening with parents?
Screening, not hugely. I think there was concern that occasionally, people who are, their parent, they've lived in a certain part of England for all their life, and all their ancestors have lived in the same village, and they don't like the idea that they're going to be tested for some disease that is not common in Northern Europeans. In general, there's not really much resistance to it. As I say, it's part of a more general neonatal screening where lots of conditions are tested for, like cystic fibrosis as well. And it sounds very unusual for someone to specifically say, I want all the tests, but I don't want to be tested for sickle cell. And the neonatal screening works very well. There's very good coverage in the UK, and there's a good system, and more than 99% of people have testing done.
Okay. Do you think there's a reluctance in other parts of the world to adopt this?
I think neonatal screening, I think there's a cost to it as the issue. I think in general, there's a perception that, if it's a rare disease, that you'll test, hundreds of thousands of children and not pick up anything. But that is currently done. Really, phenylketonuria, which is tested for, every baby is tested for, is incredibly rare. There are, only a handful of cases each year, and whereas in sickle cell in the UK, there are 300 cases a year. And in most European countries, there'd be more cases of phenylketonuria, of sickle cell disease than phenylketonuria. And yet people test for phenylketonuria because for historical reasons. The other important thing about testing is there has to be an intervention that makes a difference of screening. And in sickle cell, the reason it's important to test babies is that you can start them on penicillin at an early age to protect against infection. And without that, we know that a proportion of children, become very unwell or even die before the diagnosis is made. Okay. So it does have one, it's a good thing to do in itself, probably, but secondly, there is a very practical reason for doing it.
Yeah. What other developments could you foresee in the future for when it comes to screening for sickle cell disease?
Well, one issue, particularly for prenatal diagnosis, is that predicting the severity of the baby. We know sickle cell disease is very variable, and some children have no problems and are completely healthy, and others are really quite severely affected and can have strokes and severe complications. And if we could predict, using other genetic markers, whether this was going to be a severely affected or a mildly affected child, then that would again be very useful information to help parents choose about what to do regarding continuing the pregnancy. We and others have been trying for a very long time to identify genetic markers that predict severity, and it's still really basically not possible to do. There are one or two things that can give you a clue, but they're not specific enough to use to make a sort of, big decision about whether to continue a pregnancy or not. But with genomic medicine developing and whole genome sequencing starting on babies and everything, then it may be, and more bioinformatic capabilities, it may be possible to give a much more precise direction, which would then add greatly to the value and the prenatal diagnosis. And so that would be an important way to provide much more valuable information to families.
That sounds wonderful. Is there any way to prognosticate in neonates at the moment?
Again, it's a good question, and the same arguments apply. And there are crude guidelines, really. You can identify, for example, boys do less well than girls, and you can predict the hemoglobin F level, and things like the presence of alpha thalassemia determine outcomes, but to a fairly small extent. I think the issue for that is, whilst at the moment there are some curative treatments, but they're all quite toxic. They all involve basically myeloablation and a risk of severe complications. So though if you could predict which children are going to have, say, a stroke, then there would be a strong argument for you giving these quite toxic curative treatments at an early stage. We've tried, and others again have tried quite hard to predict stroke and identify factors, and again, whilst we found some factors, we haven't found enough to actually, make a big decision on, clinical decision where you say yes, no, we're going to transplant them or not. I think that will change as curative treatment becomes more widely available and less toxic. Then I think we will reach the stage, as I said previously, that every fetus, every baby potentially has a curative treatment, so the need to discriminate between severe and mild will become less important.
If we were to, get in a time machine and go 50 years in the future, what would you hope for screening for sickle cell disease?
I think, to be honest, the screening is pretty good now. I think every country in Europe should test every baby born for sickle cell disease. And more importantly, it's almost where sickle cell is most common in Africa and India, there's almost no neonatal screening. So if you wanted to wish something, it would be that the neonatal screening had been set up in these countries where it would actually have a huge impact in that 80% of people die in childhood, and a large proportion of that is preventable by starting penicillin and other preventive measures at an early age. So if you could go ahead and say in 50 years, you'd really hope that Nigeria and Congo and India have a national neonatal screening program and every baby is tested.
That would be wonderful.
It would, and that would make far more difference than we make in the UK. I mean, we make a difference, but you could make a huge difference there.
Okay. Well,
and that will become more relevant as curative treatments become available. And with gene editing, I think in 50 years, almost certainly that will be a widely available treatment, and so it will be possible, potentially to, cure babies neonatally. And even more, we're not even further ahead. We're currently looking at research for doing in utero gene therapy for treating fetuses in the womb, which has some advantages. So potentially our screening could, if that becomes a feasible and effective way of treating them, it could become quite an effective, the antenatal screening will become more important so that you can.
That sounds wonderful.
It does.
Well, thank you so much for talking to us today. And thank you to our audience listening to this episode of EHA Unplugged. Stay tuned for our next episode.